And okay, I'm really pleased to be with you today. And as Angela said, my name is Karen Giblin, and I'm the founder of the Red Hot Mamas Menopause Education Program. Please forgive me. I have a little head cold today, so that's why I sound a little nasal and different things like that. Well, Roper St. Francis Healthcare and Red Hot Mamas want to provide you with much needed information about your health at menopause and health information throughout your postmenopausal years. That's why we partner together to bring you these monthly menopause education Zoom programs. And this is all new to us with the Zoom programs as well, because we've usually had these in person in auditoriums within hospitals. So we hope you enjoy this new type of venue. Well, it's our pleasure to have you with us today, and we hope that you find today's program to be helpful and informative, and that you'll join us for more Zoom programs in the upcoming months. Our topic today is hormone therapy, and hormone therapy is the use of female hormones to treat menopausal symptoms. It's a term that's used to describe estrogen, progesterone, and sometimes testosterone treatments available to menopausal women. Well, over 50 years, millions of women have used hormone therapy to treat their symptoms at menopause. However, the decision to use hormone therapy oftentimes has been pretty scary to women. This is because we've been faced with all kinds of conflicting information. It is a fact that hormone therapy is one of the most controversial menopause treatments available, but hormone therapy is also the most effective treatment out there for moderate to treating moderate to severe hot flashes, night sweats, as well as vaginal symptoms. And it certainly can improve those menopausal symptoms and improve the quality of life if you are experiencing symptoms. But with any medication, hormone therapy does carry specific benefits, but it also carries specific risk. And when it comes to hormone therapy, there are very many different treatment options available, and not all hormone therapy treatments are all the same. So our program today will give you a better understanding about hormone therapy. But first, I need to tell you a little bit about the format of our program today. About halfway through our speaker's PowerPoint presentation, and I think that's going to be around slide 11, you'll be allowed to ask questions. To do this, you have to go into Angela Poindexter's, remember that name, chat room. Angela Poindexter is Roper St. Francis's Healthcare's Integrated Marketing Manager. Angela will read your questions to our speaker, who is Dr. Richardson. Your name will not be revealed because we understand sometimes your questions are sensitive. If you forget to write your questions at that time, around slide 11, you will have another chance at the end of our program to write in your questions. I'd also like to remind you to please take our short survey after the entire presentation. This will allow you to have access to additional important resources that you might need. So without further ado, I'd like to tell you a little bit about our distinguished speaker today, which is Dr. Elizabeth Richardson. Dr. Richardson is originally from El Paso, Texas. She received her medical degree at the University of Nevada and did her OB/GYN residency at the University of Tennessee Graduate School of Medicine in Knoxville. During this time, Dr. Richardson received numerous awards, including Outstanding Minimally Invasive Surgery Resident, Outstanding Urogynecology Resident, Outstanding Resident Research Award. We're so happy that she relocated to the Charleston area. She's in private practice there. Her special interests include obstetrics, minimally invasive surgery, robotic surgery, vaginal hysterectomies, and evaluating and treating pelvic pain disorders. Dr. Richardson is married. She has a wonderful son, and she very much enjoys exercising. And I want to learn more about this. She competes in obstacle course races. So Dr. Richardson is looking forward to answering your questions. So please don't forget to send her your questions in Angela Poindexter's chat room. And once again, I thank you for joining us today. I hope you tell your partners and your friends to join us at our next Zoom meeting, which is going to be about sex and menopause. So without further ado, let's welcome Dr. Richardson. Thank you.
Thank you so much, Karen. I really appreciate the introduction. And good afternoon to everyone that's joining us today. I'm so excited to be here with you. And really thank you for taking time out of your day to meet with us and learn a little bit more about menopause and ways that we can help to manage symptoms that are associated with it. This is a topic that I really enjoy counseling patients on. It's something that we are all going to face one day. And so I think with all the misinformation that can be out in the world today, I think taking time with us so that we can give you information that is evidence-based and comes from the experts in this field is just such a wonderful opportunity for us to share with you. So thank you again for joining me. So we'll just start off with an overview of today's discussion. So in general, we'll touch on menopause, how we define it, what kind of symptoms that women experience when they have gone through menopause. We'll also talk about hormone therapies and the way that we approach it. And we'll go into details about what kind is out there, the risks, the benefits, who is or isn't a good candidate for this therapy. And then we'll talk a little bit about how we begin it, how long we use it for, and then, of course, the various vehicles in which we deliver these therapies. So we'll go ahead and get started on that. And just one last reminder to everyone, if you all would just make sure that your device is on mute so that everyone can hear me clearly. And I look forward to answering your questions shortly. So to begin, what is menopause? So we consider menopause to occur in 3 different stages, beginning with the perimenopausal phase, which leads into menopause, and then of course the postmenopausal stage of a woman's life. So with regard to perimenopause, we define that as the time that is leading up to the actual stopping of your menstrual period. For most women, this begins in your 40s. And what we typically see with this is that women are still having a menstrual period, but one of the first signs of the menopausal transition is that the cycle will begin to become more irregular. The way that typically presents is kind of a gradual prolongation in the cycle. So where typically if you have normally functioning ovaries, your period occurs, let's say somewhere between 28 and 30 days every month. We may see women begin to have a period every 40 days, every 50 days, and eventually they begin to skip periods until eventually they become so infrequent and then stop. In this phase, women may begin to have some early signs of menopause, including hot flashes and night sweats. And then we find that this transition can last anywhere between 4 to 8 years. Really just kind of varies from patient to patient, and how they experience it can be very variable as well. From there, we transition from perimenopause into menopause. And by definition, menopause is when you have had a lack of a period for 1 solid year. And this is an indication that your ovaries have stopped or are making very minimal estrogen and progesterone. And those are the female hormones that signal a menstrual cycle. So once the ovaries stop producing those in large amounts, then we see periods slow down and then stop. And after 1 year of no period, by definition, you have gone into menopause. It is a normal part of the aging process for all women. We will all go through this at some point in our lives. The average age for menopause in the United States is about 52. But, you know, again, it can be very variable. So some women may go through it a little bit sooner. Some may go through it a little bit later. And we see a time frame of about 5 years on either side of that. So sometime between 47 and 57, give or take. And the way that we experience this can be so unique and individualized. So some women may not have any signs of menopause, like hot flashes or night sweats. They just kind of cruise on through menopause and not have any problems. Some women will have very mild symptoms that are a little bothersome, but don't really impact their quality of life very much. And they're able to just kind of manage them on their own and not require any kind of therapy for it. There is a significant proportion of the population though that will have really severe symptoms that affect their sleep, their sexual health and function, and their overall quality of life. So everyone is a little bit different in the types of symptoms that they experience, the severity of the symptoms that they experience, and the length of duration for how long they experience these symptoms. So once you've reached that 1 full year of lack of period, again, you are in menopause. And then from that point, from when you've had your last period to the end of life, we would consider you to be post-menopausal. And when we kind of look at the average length of a woman's life, it ends up meaning that about 1/3 of most women will spend their time, or excuse me, 1/3 of your life is spent in the postmenopausal period. So it's kind of important to realize that this is going to be something that you see for a prolonged period in your life, something that we're all going to experience, and is going to be a significant part of who we are. Some things to take into consideration: once you're postmenopausal, you no longer have to be worried about menstruation, of course, but also women do not need to be concerned about the possibility for pregnancy. Once you've gone through menopause, it is not possible for you to conceive. A lot of times, the symptoms of menopause with some time will resolve, such as hot flashes and night sweats. But there are some instances where we can see those symptoms in a much milder form occur for the duration of life. So some women pretty late into life will report that they do experience mild hot flashes that kind of come and go. I would say vaginal dryness is probably the one that I hear from women the most often about. Definitely hear issues with dryness and painful intercourse late into 6th, 7th, 8th decades of life. Something that is important just to touch upon is early menopause. So again, the average age of menopause is 52 years in the US. We do consider menopause to be premature when women experience it prior to the age of 40. In some instances, it's kind of a spontaneous thing. We're not really sure what causes it. We call that primary ovarian insufficiency. In some cases, like listed here on your slide, we can pinpoint the source of it. And these are probably the ones that we see more often. So one includes medical therapies. So for instance, if we have a woman in her 40s that's been diagnosed with breast cancer and goes through treatment for that, including chemotherapy and radiation, oftentimes we'll see them go through a menopausal type phase where they're not having periods. They may experience hot flashes and night sweats. And then we especially will see that kind of lasting over a period of time if someone's on maintenance therapy. So again, with that example of breast cancer, if we have a woman on tamoxifen, they may find that they're not having menses while they're on that therapy. In some cases, once the therapy is completed, women may resume having a normal menstrual cycle. In other cases, women do not see return of their menses. And so that would be one example of early menopause for medication therapy. We also will see this oftentimes in cases of surgical menopause. And so in some instances, a woman may have to have her ovaries removed surgically. In medicine, that's a procedure that we call a bilateral oophorectomy. And this basically will put a woman into menopause immediately. In most instances, we see some symptoms that are associated with that, such as the hot flashes and the night sweats. And because we lack that hormonal signaling to the uterus, we also see that women will stop menstruating if their uterus is intact. So in the instances where we have someone that has early menopause, it is important for a woman to see her provider, her gynecologic provider, to talk about hormone replacement therapies in women that are candidates. Of course, that may not be a possibility if you've had chemotherapy or radiation for things like breast cancer or uterine cancer. We'll touch more on that a little bit later, but in cases if it's a primary ovarian insufficiency or if you're in surgical menopause, we definitely want to see you so we can talk about the pros and cons of initiating hormone replacement therapy. Because what we see in women that go through this process before the age of 40, you do have some increased risk for things like early onset heart disease, stroke. And in general, when we start these therapies with the appropriate timing, we can just in general prolong your life. So just something that we don't see often, but is important for women to know. So with regard to early menopause, just to give you a few more risk factors, things that you may want to talk with other family members about, we talked about things like cancer treatments and surgeries being able to affect this. But some other things that we commonly see premature menopause with include autoimmune disorders such as adrenal insufficiency. We can also see it with certain viruses such as mumps and cytomegalovirus. And interestingly enough, we actually can see earlier menopause in cigarette smokers. And so what we see is that approximately 2 years sooner than we see on average, smokers will end up transitioning through this phase. So symptoms. What kind of symptoms can women expect to experience in menopause? So the ones that you see in this diagram here are probably the ones that we hear most commonly for women. We've already touched on several of them. So things like irregular menstrual cycles, hot flashes, night sweats, pain with intercourse, mood changes, kind of irritability, emotional liability where you're kind of up and down. That's another one that we see commonly. Sleep problems is a big one, and issues with cognition or memory. In some instances, women may start to experience more persistent or more frequent headaches, joint pain. Problems with weight gain is one that we commonly hear about. Dermatologic changes like dry skin, dry eyes, dry mouth, and then hair loss and thinning is another thing that we can definitely hear women concerned about. So thankfully enough, with how common this is, and because all women are going to experience this, and it's definitely a major concern, we have a therapy that is very effective and ways that we can certainly address this for women that feel like their symptoms are impacting their quality of life and want some help with that. So what we counsel women on is the option for hormone therapy. So what is hormone therapy? What it is typically medications that we use to help relieve the symptoms of menopause. I would say the probably number one indication for this is things like hot flashes and night sweats that are impacting a woman's quality of life. We use female hormones for this purpose. And so specifically, we're talking about things like estrogen and a progestin. And what primarily causes the symptoms of menopause is that withdrawal of estrogen. So once the ovaries decline in their production of estrogen, it's that withdrawal of that specific hormone that is going to lead to the symptoms of a hot flash, night sweat, vaginal dryness. And so our goal is to supplement that hormone in order to get these symptoms under control. So these are the different types of hormones. And so depending on the patient, symptoms, your medical history, these are the types of medications that your provider may consider and will discuss with you. So we may think about doing an estrogen only, a progestin only medication. And typically the progestin is in combination with the estrogen. We don't really have an indication for using the progestin alone, but we'll talk a little bit more about that momentarily. We may also consider doing a combination of an estrogen and a progestin, and then also the combination of estrogen with other medications. And we'll touch a little bit on some of those potential treatment options as well. So kind of getting into a little bit more on those different types of hormones and which ones we're using and for whom, I would say the main thing that's going to determine that is whether or not a woman has a uterus intact, meaning have you had a hysterectomy or do you still have your uterus in place? So women that have gone through a hysterectomy are good candidates for estrogen therapy alone. So the reason that we do that is that if you still have your uterus in place, estrogen supplementation can stimulate the uterus and overstimulate the lining, which can lead to an overgrowth of the lining. Eventually, that may lead to some cancerous changes. So we see precancers and cancers of the uterus in women that have an excess exposure to estrogen, whether that's via medication or just naturally occurring, which can occur in the case of obesity. And in order to help protect women when they're on this type of medication, we also will put them on a progestin. So if you have a uterus in place, we're giving you estrogen to manage your menopausal symptoms, but we are also adding in that progestin. And what that does is it helps to protect the lining and prevent some of those precancerous and cancerous changes. So important that if you have a uterus that we put you on that combination therapy. If you've had a hysterectomy, then we're very comfortable with doing the estrogen alone to help manage your menopausal symptoms. And just so you know, these are oftentimes referred to estrogen therapy if we're doing the estrogen alone versus estrogen progestin therapy or EPT when we do the combination. So, do I need a break, Angela?
Yeah, let's take a break and give you a break from talking and then see if we have some questions. We did get questions on the pre-survey. So what I would like to do is read those first for you, Dr. Richardson.
Perfect.
And to get those answers. So question 1, what can help with sex drive and hot flashes after cancer stage 1, grade 1?
Very good question. As we already kind of touched upon, women that have a history of cancer may not be a great candidate for some of these hormone therapies that we are talking about. And it'll really depend on what type of cancer the woman has had. In cases of breast cancer and endometrial cancer, it may be a type of cancer that is responsive to hormonal therapies. And in that case, I would say that you're not a great candidate for these type of medications. Fortunately, we do have some other options. I think talking with women about the importance of sex therapy, so talking with the sex therapist to maybe address some of their concerns and ways to approach those concerns in a conservative manner, doing things like lubricants. I really like the water-based lubricants to use with intercourse. If someone is experiencing some dryness and pain or discomfort with intercourse, that is definitely one of the first steps. There are also great vaginal moisturizers that you can purchase over the counter that just help to nourish and moisturize the tissues and can make some of that pain with intercourse a little bit more manageable. And then there's also an app that I always recommend to my patients. It's called Rosy Wellness. It's a really wonderful application that was developed by an OB/GYN and has a lot of short videos on ways that women can go about addressing their concerns with libido in a conservative fashion, just kind of empowering you and giving you tips and tricks and things that you can do to address problems with libido without having to potentially expose yourself to hormones that you may not be a good candidate for. Again, this is also individualized. So I would say someone with that type of history should definitely meet with their gynecologist so that they can review what their history is, what kind of treatments they've gone on under. And oftentimes I may even reach out to someone's oncologist because in some cases we might be able to offer something like a topical vaginal estrogen to someone that's had a breast cancer in the past, but it's really just going to depend on the patient. It has to be something that's very individualized.
Excellent. I am 67 and still taking HRT by choice. I don't want to quit ever, but not sure if it's wise medically to continue.
And that's something I hear so often from women. Again, and it's just one of those things where sometimes these symptoms that women are experiencing, the hot flashes, the night sweats, can be so severe that they have a real impact on someone's quality of life. And they say to me, I can't live like this. So when I have a patient that is like experiencing that, I just counsel them and say, I do not want to take something away from you that is offering you so much benefit, but I just want to make sure that you understand the risks that are associated with this. And so we'll talk a little bit more about what those risks are, but as long as the patient is fully informed, can express to me understanding of what those risks are and say that they're willing to accept those risks in exchange for the benefit that they receive from it and the improvement in their quality of life, then it's something that I feel comfortable continuing a patient on, as long as they can say that they understand the risks and that it's worth undertaking them because of how much better they feel while they're on the hormones. And so again, it's just something that you have to decide for yourself in conjunction with speaking with your provider to decide whether or not there's enough of that exchange there for you to continue with that medication.
Excellent. If I'm post-menopause and no longer able to have intercourse due to severe pain, is there anything that can safely be done? Good question.
Yeah, absolutely. So we talked a little bit already about lubricants, really like the water-based lubricants. Astroglide is one that you may see really commonly in the pharmacy that I recommend. The vaginal moisturizers are really wonderful as well to just moisturize and nourish the tissue. That one's a little bit different. So the lubricant you just use for intercourse, so you're going to use it during the actual episode of intercourse. The moisturizer is something that you use on a regular basis. So you're going to do this 2 or 3 times every week. So it requires some maintenance. But when you do that, some women do have really good results and feeling like it helps improve that dryness, especially when you use it in conjunction with the lubricant. Some women also have pain with intercourse after menopause due to something called atrophy. So once the ovaries stop producing estrogen, it can induce some structural changes in the vaginal tissue. It can become thinner, a little bit weaker, more prone to irritation, infection, and discomfort. And with that, it can even decrease the caliber or the size of the opening of the vagina. And so that can lead to some discomfort with sex as well. For that, I would recommend that a patient consider something like a vaginal dilator. And you can find these actually really easily online. You can even find them on Amazon. It's small devices that increase in size gradually. And you use that with a lubricant to kind of gently and slowly dilate the vaginal opening until it is more comfortable to accommodate insertion during intercourse. So that's definitely something. And another thing women can consider is pelvic floor physical therapy. So we have wonderful specialists in the women's field in physical therapy. So physical therapists that have specialized in women's health and can help women learn how to use their pelvic floor and be able to manage some of that discomfort and pain that women experience with intercourse. Again, that will be kind of individualized and depending on what it is that's causing your discomfort with intercourse, but lots of great conservative options that are safe to use.
Excellent. We have 2 more. What determines the right balance between estrogen and progesterone?
Yeah. So we basically, the official guidance on that is that we should use the lowest effective dose of the hormone for the shortest amount of time possible is our official guidance on that. So depending on your level of symptoms, if we deem your case to be moderate, we would probably start you on the lower doses of both of these hormones, whether it's via the oral formulation or a patch. We would start someone on a lower dose and give it some time and see how they feel, see if they get adequate relief of their symptoms. We can titrate up from that lower dose until we get a woman to a level where they feel like their symptoms are adequately controlled. If someone's having really severe symptoms that are occurring daily and severely affecting someone's quality of life, in that instance, we might decide to start them on a more moderate range dose to go a little bit higher to try to get their symptoms under control if we think that's warranted. And then we just kind of adjust from there. So the dose that you're started on will really depend on the frequency and severity of your symptoms.
Excellent. And does all hormone therapy cause thinning head hair and unwanted hair growth?
I wouldn't say that that's something that we see in general. Dermatologic conditions like hair thinning is something that we see just with menopause overall. And, everyone kind of will experience different side effects with these different medications. That's not something that I hear commonly. I will say, and we'll talk a little bit about testosterone therapy. One significant side effect that I counsel women on with testosterone therapy, particularly, is that potential for male pattern hair growth or even thinning, but that's really specific to testosterone. It's something that we monitor really carefully for. But I would say in general with the estrogen and progestin, that's not something that I see occur frequently for women.
So that's the last of the pre-survey questions. If you have additional questions, you can send them in the chat now, or we will also do another Q&A at the end. So I'll give you a minute or so to see if anybody sends anything in the chat for now, or feel free to save them for later. Those were actually very good questions. Very good.
Yeah, great questions so far.
Yes, I learned something on that one.
Good.
All right, doesn't look like anyone's typing. Okay, oh, here we go. Here's one. Any help with weight gain?
Mm.
And that's something that we hear a lot from women in menopause. Unfortunately, as women transition through this period in life, we do see a drastic drop in our rate of metabolism. And so a lot of times things that we have done for a really long time that worked for us and helped us maintain that healthy weight with exercise and diet just don't work as well. I think that it's important to have a conversation about that and changes that you can make in your lifestyle that may help to address your concerns with weight gain. The other thing I think that women are really bothered by is that the weight gain tends to be central. So kind of in that belly area, which is so frustrating, can be really tough to manage. Unfortunately, we just don't have good evidence to suggest that hormone therapy is going to be effective for this. So when I counsel patients on this, I talk a lot more about lifestyle factors and, how often are you exercising? What is your diet like? What kind of things can we eliminate from your diet to help in your effort for weight loss? And in some instances, I feel like women are a good candidate for medications to assist with weight loss, and maybe in some instances even surgical intervention. I typically will refer on to our weight loss center for that because it's not something that I'm as versed in, but definitely a major concern with options for management, but much, much more difficult, unfortunately, in the menopausal period.
Okay, what is the lowest dose of hormone replacement therapy?
So it'll depend on what formulation. So if we are doing the oral formulation, we can go as low as 0.025 milligrams, and that's something that you would take daily. We can go up to 0.5, 1 milligram. Highest dose I will see someone use is 2 milligrams daily. That's a pretty high dose of that medication though. And I'm a little apprehensive about using that. Again, it would be kind of a risk-benefit conversation that you would have with your physician. And then we also have the patches. And the lower dose that we use on that, I believe, is also 0.05, but don't quote me on that. I'd have to look that one up again. More often, I'm using the 0.1 milligram per 24 hour, but it kind of depends on what type of hormone we're using.
Okay, we have one more and a comment, and then we'll save the rest for the end. What is your thought about hormone therapy for someone with osteopenia? Is it okay to continue for that additional benefit?
So we definitely in the literature see good benefit for bone health. So women that are on hormone replacement therapy tend to have decreased rates of things like osteopenia and osteoporosis. It is not currently one of the FDA indications for hormone replacement therapy. However, I would not start a medication on hormone therapy if that was their main concern. I will typically do it for things like hot flashes and night sweats, and then consider the assistance with their bone density to just be a side benefit. And so definitely some good benefit to be had in that area, but not the main indication for this therapy.
And the one comment was on the dose. One young lady said, I take 1 milligram, 1 mg, and 5 mcg.
Yeah, so I would say that's kind of a moderate range dose, definitely safe to take as long as you've had a conversation with your provider and based on your symptoms, they thought that that was the best dose for you to be on. Some women would opt to try to decrease their dose over time. A lot of women choose to just kind of stay on the dose that they're on if they're feeling well.
Thank you all for the questions. Very good questions. Okay, Dr. Richardson, back to you.
Perfect. So to continue our discussion on hormone therapy, one of the most important things for us to do is talk about the risks and the benefits. And having the information on this is what's going to really help to guide you through deciding whether or not you think it's a good fit for you. Again, it is based on your unique characteristics. It will require us to take a good, thorough history to understand what kind of conditions you may or may not have experienced in your life. What are your symptoms? What type of symptoms you're experiencing, how frequently they're occurring, what is the severity of them. So it's important that you have a provider that you're comfortable with, that you think you have a good rapport with, and that you can talk about these concerns with. Some things for you to know about just in general, we consider hormone therapy to be a reasonable option for women up to the age of 59 and who are within 10 years of going through menopause. So we tend to try to avoid initiating these therapies if you are over the age of 60 and as well as more than 10 years out from menopause. And the reason for that is that we do see some increased risk for things like cardiovascular disease when we start this medication in women that late. So another thing to discuss is once you've decided that you would like to move forward with hormone therapy, and once you've been established on it, it's important that you have regular contact with your prescribing provider to talk about, okay, this is where I'm at this point. Is this something that I want to continue? Let's talk about the risks. What are the benefits? And so on a yearly basis, when I have a patient that is on these hormone therapies, I'll say, these are the risks that we're facing with this medication that we have you on. Based on the symptoms that you were experiencing, is this something that you want to try to come off of? Do you want to just continue at this point? But it's important to continue to have that discussion and make sure that you understand the risks and that you want to continue it. And so having a frequent conversation with your provider about that is very important. And in some instances, I'll have that discussion with a patient and she'll tell me that, yes, I want to try to come off of the medication. We'll begin the weaning process. And then they may find, oh no, my symptoms are back. I can't handle this. I want to stay on my medication. And so we can resume the therapy in that case. In general, we try to stop the medication somewhere between 3 and 5 years after starting it. However, in some instances, women want to continue it beyond that time based on their symptoms, which again is acceptable for many of us as long as you understand the risks associated with it. And so we do have many patients that go well beyond that 5-year time frame because we can see the symptoms of menopause really for some people last somewhere between 10 and 20 years. So this is going to be very individualized, but as long as you're having that discussion with your provider and understand the risks, definitely see women that will stay on this for a prolonged period of time, very late into life in some instances. So benefits, these are the things that we love about hormone therapy and what really kind of drives us to start so many women on this medication. Many, many benefits to be had from this therapy. And so this is a list of just some of them. So in cases where we put a woman on an adequate effective dose, it can nearly eliminate their hot flashes and night sweats. In a lot of cases, at least make them so that they're much more tolerable. In general, we can see it assist with things like mood changes. So women will report that they have elevated mood. Definitely an improvement in sleep is a big one that I see as well. We talked a little bit about bone health. So it can help to prevent osteoporosis and reduce the fractures that can occur with that. From just things that we're at increased risk for as we age, this can also help to reduce our risk for things like heart attack, colon cancer, reduce the likelihood of developing type 2 diabetes. A lot of women are excited about the potential for improved sexual health and wellness, so enhanced sensation, improved pelvic floor musculature. And then we can actually see that overall, it just helps with the body deterioration. So women will report feeling that their skin appears smoother, reduce urinary urgency, improve muscle tone overall. Certainly, we have seen that estrogen, and when we use it systemically, when we say systemically, we're referring to things like the pill, the patch, and the vaginal ring, as opposed to local therapy. So that is just when we use estrogen vaginally, and that can be in a form of a pill, cream, and ring as well. But when we're using a systemic type hormone, that's definitely been shown to be the most effective for managing things like hot flashes and night sweats. And again, with or without the progestin, depending on whether or not you have had a hysterectomy. We use the systemic as well as the local estrogen therapy to help address vaginal dryness and pain with intercourse specifically. A lot of times we'll have a woman that is on the systemic hormone, it's effective for their hot flashes, they're feeling much better from that standpoint, but still having some concerns about vaginal dryness and pain with intercourse. And a lot of times I will start a patient on the systemic therapy in conjunction with the local therapy, very safe for us to use. When we use estrogen locally, at the vagina with the patch, or excuse me, the pill, the cream, or the ring, we see very minimal systemic absorption when we use it vaginally. So it's safe to use in conjunction, and sometimes can kind of give that little added benefit to help with that vaginal dryness. And as we mentioned, estrogen helps to protect against bone loss, and the combination therapy can help reduce the risk for colon cancer. So lots of really wonderful benefits to be had from being on this therapy. Of course, the reason that there is so much apprehension about using hormone replacement therapy is that research has shown that there can be some significant risks associated with it. And so, of course, important for us to touch on that. Risk for endometrial cancer. So as we mentioned previously, estrogen can stimulate the lining of the uterus, which may induce precancerous and cancerous changes in the uterus. Adding the progestin therapy can help to reduce the risk of that occurring. However, there is still some risk there. There is also an increased risk for breast cancer. Fortunately, for women that have had a hysterectomy and that are started on the estrogen alone, we don't tend to see the increased risk for breast cancer until after being on this therapy for 7 years. And if you're someone that is on it for the 3 to 5 years, obviously we're not going to see that increased risk there. However, the combination of the estrogen and the progestin therapy that we use for women that have their uterus intact, we do see a small increase in the risk for breast cancer. So can't stress enough the importance of doing your self breast examinations, having your clinical breast exam with your provider every year, and then staying on track with your mammogram screening. In general, we recommend that for all women, whether or not you're on hormone therapy, but definitely being kind of in tune to those changes if you're on this therapy, so that we can detect those changes earlier on. There is also some increased risk for heart attack when a woman is on the combined hormone therapy. This is an age-related risk, and we can say that about women in general. So the older that we get, the increase our risk for cardiovascular disease or heart disease. And that's definitely also affected by some of the other comorbidities, things like obesity, high blood pressure, diabetes. And being on this hormone therapy in the setting of these other conditions can also increase your risk. Another major side effect that I mentioned to women is the risk for blood clot. So specifically deep vein thrombosis, or a clot in the leg, which can eventually lead to issues with pulmonary embolus or stroke. And then we also see a small increase in the risk for gallbladder disease for women that are on these therapies. So important that you're getting your regular screening labs done so that we can identify any issues with things that could affect your gallbladder as well. So hormone therapy, I kind of touched on, there's different types and different ways that we deliver it. So there are 3 different types of estrogen that are produced in the body. And one of the medications that we use, it's called estradiol, is one that is made specifically to mimic the body's natural estrogen. So the 17-beta estradiol, it has the same chemical structure. We also have conjugated estrogens. And so that's actually something that we derive from the urine of pregnant mares. And it's a common component in some of the hormone therapies that we use. Lots of good clinical data showing that it is safe to use. And then there's lots of synthetic estrogens as well. And those are the ones that we typically use in contraception. So someone that has not gone through menopause yet and we have them on something like a birth control pill, the ethinyl estradiol is a synthetic estrogen. So progesterone is another natural occurring female hormone that is produced by the ovaries. So the couple of medications that we have, so we have a progesterone that is synthetically derived in the laboratory that was developed to mimic our natural occurring progesterone. So they have the same chemical structure. And so lots of different forms of the progesterone. And again, just kind of in general, it's one of the hormones that's involved in our natural menstrual cycle, helps to establish a normal, healthy pregnancy, but also kind of promotes good uterine health, like we talked about, using that progestin to protect the uterus against estrogen in a postmenopausal patient. As far as dosing is concerned, So there are a couple different ways that we will use estrogen. If you are using the oral form of estrogen, that is a daily medication. So you're on a pill every single day. We also have the transdermal formulation. So things like the patch, which we use a couple times a week. There's also vaginal ring that you can use that you change about every 3 months. And then a couple different ways that we use progestins for women that have their uterus intact. So sometimes we'll use it in a cyclic fashion. The benefit of doing that is that we don't see it as high of an increased risk in things like breast cancer when we use it cyclically. So what that means is you take your estrogen every day, but you're only going to take your progestin for between 10 and 14 days of the month. And so we're reducing your exposure to that progestin when we use it in that cyclic fashion. Alternatively, some women find it difficult to manage that schedule, aren't able to keep on track with like doing the first 12 days of the month or whatnot. And so some women opt to do continuous dosage of that. So you could do estrogen and progestin daily as a separate formulation. So you're taking 2 pills versus we do have continuous combined therapy. So some companies have combined the 2 medications into a single dose that you take 1 time every single day. So what type of medication we use, the vehicle, whether the pill, the patch, the ring, the doses, how often you're taking them is all going to be very individualized based on discussion with your provider, what your goals are, what your symptoms are, what you think that you could do most reliably. A lot of it will depend on cost as well. And so really kind of having a specific conversation about what your goals are will help you to determine which of these is going to be the best for you. And just want to briefly touch on the topic of testosterone. And so, definitely testosterone therapy is not a one size fits all. There are lots of things that go into considering whether or not a woman is a good candidate for this type of hormone therapy. The indication that we use for testosterone is issues with sex drive. So if a woman is concerned about her decreased libido that occurs in menopause, testosterone therapy is something that we can consider in order to assist with the libido. This is an off-label indication, so it's not FDA approved, but there is good data out there supporting the efficacy in that we see good results in women that are postmenopausal on the testosterone therapy when specifically talking about their decreased libido. Not everyone, again, is a good candidate for this. We would want to go through your medical history. We would be concerned about things like cardiovascular disease and whether or not you have issues with your cholesterol levels. Some of the side effects I stress that women should know about are increased risk for cardiovascular disease. And then things that we can see with testosterone, because it is a male hormone, so we can see increased acne, that male pattern baldness or hair growth, so like the hair on the chin, the chest, the abdomen, and also sometimes deepening of the voice. And some of these side effects can be irreversible. So it's really important that if you opt to start this medication that you're monitored closely. So I'll always check a baseline testosterone level on a person before I start it to make sure that their level is not already elevated. And then we do require some lab testing to make sure that once you're on the therapy that we are keeping your level controlled and that we're not giving you excess that would put you at increased risk for some of those side effects. So want to point out at the bottom of your screen, the global consensus position statement. So this is coming from medical experts in this field. And it's a really great, concise way to kind of describe this therapy to you. So I'm just going to read it directly off of the screen, but you'll see the international panel concluded the only evidence-based indication for testosterone therapy for women is for the treatment of Hsdd. That stands for hypoactive sexual desire disorder or low libido, with available data supporting moderate therapeutic effect in postmenopausal women. So we don't use this in women that are still menstruating. So you're premenopausal, only if you're postmenopausal, with good evidence for a therapeutic effect. And it says there are insufficient data to support the use of testosterone for the treatment of any other symptom or clinical condition or for disease prevention. So definitely not using this for any other menopausal symptom or risk. Specifically, it's to address libido. And if it's something that you're interested in, I would say just having that detailed discussion with your provider to figure out whether or not this is going to be a good option for you. And, this is kind of a little overview slide because we've kind of talked about this throughout, but there are several different delivery methods. So different delivery methods and preparations, and it'll just kind of depend on what your preference is, cost, what you think is going to be the best for you. So we have the local therapies, which are tailored to specifically address local vaginal symptoms. And so a lot of times I'll do the vaginal cream for women. I'll start off with that one. It tends to be the most cost-effective, generally easy to use. There's also a tablet and a vaginal ring. And then with regard to the systemic hormones, so these are not just acting at the local level, but kind of throughout the body. And this can be delivered by mouth. So the pill that we take daily, through the skin, so patch, foams, jellies. And then the vaginal ring, which we have a vaginal ring that you can use for local dosing, so that low dose. And we also have a vaginal ring that is higher dosing that can work systemically. So vaginal ring for local and systemic effect. And you wouldn't use both at the same time, obviously. You would just use the systemic if you were having hot flashes and night sweats. And so there are certain people or women that are not good candidates for hormone replacement therapy. Just right off the bat, we would say we recommend against these therapies in these women because the potential risk that's associated with it outweighs any potential benefit that they would have. And so that would include women with breast or endometrial cancer, as well as if you've had a personal history of stroke, heart attack, blood clots, or liver disease. Again, with any of these types of conditions, you would have an unacceptable risk, and we would say there's not enough benefit there to support you being on these medications. And then obviously we don't recommend it for women that are pregnant, but again, in menopause, no chance of pregnancy, so not something that we're as concerned about. But of course, if you ended up somehow being pregnant after menopause, we would say to stop this therapy. Potential side effects of hormone therapy, the ones here on your screen in red are the ones that we see most commonly. Definitely vaginal spotting. If you're on the cyclic progesterone, we can actually see a significant proportion of women experience this, up to like 80–90%. Breast tenderness, swelling, headaches, fluid retention. So kind of thinking about things that occur around the same time of your period, because these are all hormonally driven. Nausea, if you're using the patch, you can have some local irritation under where the patch is located on your skin. A lot of these symptoms can be addressed by just adjusting your dose. So if you're having symptoms that are really bothersome and unbearable, we would talk with you about making some dose adjustments, bringing you down, trying to get you to an effective dose that manages your symptoms while minimizing the side effects. All right. So another thing that I talk with a lot of women that are in that perimenopausal transition. So haven't quite gone to menopause. It hasn't been that full year without a period. You're having irregular cycles. A lot of times that can be accompanied by really heavy nuisance bleeding. These women are an excellent candidate for a low dose contraception hormone. So things like a birth control pill we will use as a woman is transitioning through menopause. The reason that I like it is it can regulate your cycles, also make them a little bit lighter and less painful. And they do have a lot of the same benefits that women see with hormone replacement. So helping to preserve the bone density, so reducing that risk for things like osteoporosis, reduces the risk for ovarian and endometrial cancers. Of course, we need to kind of individualize this as well. If you're a smoker, have high blood pressure, cardiovascular disease, you're not going to be a great candidate for this therapy. But for women that are healthy and going through that perimenopausal transition, if they're wanting some sort of hormone therapy to help regulate their cycles and symptoms, a low-dose birth control pill can be a great option for them. Once a woman has transitioned through menopause, then we'll typically recommend taking them off of that contraception dose and transitioning them to the menopausal dose. And so a lot of times the way that I approach that, once I have a patient that's reached that average age of menopause, sometime between 51 and 52 years, I'll say, all right, well, let's take you off of this pill. Let's watch you for a few months, see how things go. We either see women continue to menstruate and I say, okay, your ovaries are still working. Let's put you back on this low dose hormone, versus no issues, they're in menopause, they're not having any problems, and we can just kind of watch them, versus in menopause, having really severe symptoms associated with that. Let's go ahead and start you on a menopausal dose of the hormone replacement therapy. So just kind of depends on how someone does once we take them off of that medication. And then again, this is just kind of the consensus statement. This is coming from several expert societies. So we have the North American Menopause Society, or NAMS, American Society for Reproductive Medicine, and the Endocrine Society. And so this is good. Another just kind of overview slide that I'll read to you. So hormone therapy is an acceptable option for relatively young, so up to the age 59 or within 10 years of menopause, and healthy women who are bothered by moderate to severe menopause symptoms. Individualization is key in the decision. And consideration should be given to the woman's quality of life priorities, as well as her personal risk factors, such as age, time since menopause, and her risk of clots, heart attack, stroke, and breast cancer. And I totally agree with this. There's no question that hormone therapy has an important role in managing symptoms for healthy women during menopause transition and in early menopause. And so, of course, we're always getting more and more information on these therapies, and kind of moving forward, looking out for more information to help us guide so that we can keep women as healthy and happy and with the best quality of life as possible. As far as treatment, it's definitely not something that's absolutely necessary. So oftentimes I'll have a patient in my office that is in menopause, but not really having symptoms at all, or having very mild symptoms. And I'll say, you know what, you're doing great. I don't think that this is something that we necessarily need to do for you. There wouldn't be enough benefit in that instance for us to accept that risk. And so it's not something that is necessary. It's just aimed at treating those signs and symptoms of menopause. And then as far as women that are having really bothersome symptoms, but they aren't good candidates for hormone therapy, and that could be due to some of the things that we already talked about, there are some non-hormonal options available. So there are several antidepressants on the market that have been shown to be beneficial when we've done research. There is one formulation that is FDA approved. It's known as Brisdell. It's a very low dose of paroxetine. You may also know it as Paxil, which is what we commonly use it for in depression, but there's a lower dose called Brisdell that we use to help with menopause symptoms. We also see that the anti-seizure medication gabapentin and an antihypertensive called clonidine can be very effective at helping to reduce hot flashes and sleeping problems associated with menopause. There's kind of a newer drug too called Selective Estrogen Receptor Modulators, or SERMs. These medications are very interesting. They can act to have a positive effect in some areas in the body and no effect in other areas of the body. So specifically, a SERM can help to manage things like hot flashes and night sweats without increasing your risk for things like breast cancer and endometrial cancer. So we're seeing more SERMs kind of become available. One that I see commonly is called Duav. It's the SERM combined with an estrogen. And so that would be another good option to consider if you are a candidate for estrogen, of course. And then with regard to just things that you can do at home on your own, strengthening your pelvic floor. So doing things like Kegel exercises can help with your urinary continence, pelvic health and function from a sexual standpoint as well. Can't stress enough the importance of eating a healthy, balanced diet, focusing on fresh fruits, veggies, whole grains, really trying to minimize things like fatty foods, fried foods, sugars. Exercising regularly, so trying to stay active to reduce your risk for things like heart disease, osteoporosis, as well as diabetes and hypertension. And then avoiding tobacco use, of course, just lots and lots of reasons for you to do that, but especially from a women's health perspective, just to reduce some of the risks for heart disease and osteoporosis as well. And then real briefly to touch on bioidentical hormones, it's probably something that you hear a lot about. There are lots of clinics out there that offer this service. So these are derived from plant sources. So there are some commercially available products that are not FDA regulated, and then you may also see them in a compounded preparation. So things that are being formulated within a compounding pharmacy. So these are made from a healthcare provider prescription that is compounded by a pharmacist. And because they are not FDA regulated, the American College of Obstetrics and Gynecologists, which is kind of our governing body that gives us recommendations based on best evidence, they only recommend that we use the FDA approved hormone therapy over these compounded bioidentical hormones, just because there isn't a good way to regulate these and to monitor them for safety. So our recommendation is to use the FDA approved, clinically studied medication therapies over the bioidentical hormones that may have some adverse unknown risk associated with them. So this slide just kind of lists some potential questions that you can ask your provider if you were going through menopause or you believe that you're postmenopausal. So these are some questions that you can bring up with your provider to try to have an informed discussion with them and to try to guide the conversation on whether or not hormone replacement therapy is something that you should consider. And then these were our resources for today's presentation. And that's all I have for you.
Thank you, Dr. Richardson. Let's open it up again for some more questions. Does anyone have any questions for Dr. Richardson? Please put them in the chat. Don't be shy.
While the questions are getting typed, Karen, I'll answer your curiosity about my obstacle course races. So really, really fun. The main ones I've done, they're called Tough Mudder. I've done a couple other smaller ones, but it'll be like a 10-mile race with obstacle courses kind of interspersed throughout. So one of the ones that is really memorable, it was called Arctic Enema. It was this giant tub of ice water, and you slid down a slide into this giant tub of ice water and then had to wade through it. And then there was a partition in the middle and you had to dunk your head underneath and go under the partition. When I see people now dunk themselves in ice water, like freezing water, I just feel pain. It was pretty remarkable, but really lots of fun. I always do it with my girlfriends. It gives us good motivation for training and just something to do together that is fun and that we bond over, and kind of a good brag that we can say, you know, we did this crazy race with all these obstacles. It's a lot of fun. Unfortunately, COVID really put a damper on it. I haven't done one in some time, but looking forward to doing some in the future because they are a lot of fun.
Well, you certainly are an inspiration to all of us. And it's certainly, like you mentioned before, all the exercise will really help with the weight gain for sure.
Oh, absolutely. You know, I always kind of talk about that with patients, and especially for anyone out there with younger women in your families. Even when I see younger women in my office, I say, you know, if I ask them, are you exercising? And they say no, I say, you know, you're healthy, your weight is normal right now, and that is great. But it's so important to establish the routine now when you're young and you're healthy, and really making it a lifestyle. So as we mature and we get older, we start to see more of these issues with difficulty with weight loss and higher rates of diabetes and high blood pressure. Having already established that lifestyle just makes it so much easier to maintain that. I really feel for a lot of my patients that start to see some of these issues and have just some difficulty with establishing that routine. And I try my best to kind of support them through that. But I really think any of us out there with young women in our families and just talking with them about focusing on healthy diet and exercise at a young age will really just set you up for success later on.
But as you mentioned before, a lot of women, will have the hot flashes, the night sweats, they're not sleeping. They'd rather go to their lazy boy recliner than exercise because they're just totally exhausted because of the symptoms associated with menopause. So it's best, as you mentioned before, to get the symptoms under control, and then you're going to feel like you're ready to exercise.
Yes, absolutely. I am such a proponent for hormone therapy because I see it have such a drastic improvement on the quality of life that my patients experience. And so I think just having that informed discussion and understanding that there are lots of women where the benefit of this medication heavily outweighs the risks associated with it, and trying to get yourself to that quality of life where you can be the most productive and meet the goals that you have for yourself, and be able to live as healthily as possible. I absolutely agree. I think that there are a lot of women out there that don't know that they're a good candidate for this, and could potentially really just make their life better overall.
Do we have any questions, Angela?
Yes, we have some questions coming in. Could you go back one slide on the outsmarting menopause?
Yes.
That one. So it says, I'll read this. The information provided within these slides is intended for informational purposes only. It is not a substitute for professional medical advice or examination. Always seek the advice of your clinician, always. Then we have, thank you so much for this session. Curious, will the recording be available to watch? So much wonderful. I would like to review. Yes, I will be sending the recording to everyone. It has to be formatted and put into a YouTube link. So hopefully I can get that to you between now and the early part of next week, but you will get that as well. Comment, don't know what to do. I have vascular heart disease. Don't know what to do to stay on HRT or go off. I am healthy and fit.
Yeah, absolutely. I think with that history of cardiovascular disease, and again, I think it's something that you need to specifically speak with your particular provider about, because it's something that we would need to individualize for you. But I would say, even with that history, if your blood pressure is well controlled, you're fit, you're healthy, you're exercising, your lab work is reassuring, you may still be a good candidate for this therapy, as long as you have that detailed discussion, understand the risks, feel like you have enough benefit with the medication. It may be that you're still a candidate, but it would depend so much on your clinical picture and that discussion. So I would just say, really important that you talk with your doctor about it to make sure it's something that you're both comfortable with you being on. But if in general you're healthy, you may still be a good candidate for it.
Excellent. That was the last. Are there any more final questions? Excellent, excellent. If you come up with something as we're closing out, go ahead and send it to chat. If you come up with a question after the fact, feel free to email me. So I want to thank Dr. Richardson for this wonderful and informative session today. I learned a lot, read a lot, just to get ready for today. So I thank you for that. And just a few things, housekeeping things before we close out. So you will receive the questions to ask your doctor and the resources in an email as an attachment. So you will get those to have in front of you. The session will be recorded, and like I said, give me until early part of next week to get it formatted, and then into the YouTube link to send to everyone. Let's see. I will be sending a post survey, so if you would please fill that out, it will help us going forward. With improvements and, how we can make it better for you all and how we can present better on our end. And then we've got a few more sessions coming up. Our next session is in July on sex and menopause. So go to rsfh.com/calendar if you haven't registered already. One thing I do want to say, I know there may be some repeat registrants on these sessions. Just want to let you know, I know some of this stuff is repetitive to you, but we always have a lot of new people to join us. So bear with us as you get the information again. Karen, do you have anything to close us out? I
think Dr. Richardson did a fabulous job in explaining the risk, the benefits associated with hormone therapy, and a thorough explanation of the perimenopause through the postmenopausal years. And I want to thank you sincerely, because you've addressed this important topic in such a empathetic way and an understandable way. So thank you very much for joining us. And I hope that, our audience will share with us their evaluation, and also share with us some of the programs that you'd like to have us offer you, because we may think of a certain amount of topics, but there might be a specific topic that's on your mind that we can address in the future for your needs. I'd also like to encourage the women to, menopause just doesn't affect you. It affects your children around you. It affects your loved ones, your spouse, or your significant other. And encourage them to join our Zoom program too, because they might benefit from listening to, what we are experiencing as menopausal women. So I'd encourage you to share this with your family members as well. And keep attending our programs. We love seeing you and hearing from you. And we hope that we're bringing you very, very good information that's medically sound, so that you can make informed decisions about your health at menopause and those years beyond. So thank you sincerely for attending our program today.
Thank you, and have a wonderful rest of your day and rest of the week. Hopefully we'll see you in July. Bye.
Bye.
Thank you, everybody.
Thank you.